My name is Sarah Mott, and I'll be speaking to you today about our research using Canadian linked data to examine the relationship between active living environments and hospitalization for cardiovascular diseases. This is a project of the Geosocial Determinants of Health Research Group led by Professor Nancy Ross. I am a doctoral student co-supervised by Professor Ross and by Professor Kaveri Dasgupta from McGill University. Although Canada has come a long way and has seen a decline in the standardized rates for both the incidence and prevalence of acute myocardial infarction, heart failure, and stroke, the absolute number of people living with these diseases continues to increase, mainly a result of population growth and aging. Crude prevalence estimates tell us that we sat at around 2.21% for heart attacks, 2.88% for stroke, and 3.73% for heart failure in 2016. This also means an overall increase in healthcare burden related to these diseases. Cardiovascular diseases represent around 12% of the total classifiable cost of illness in Canada and are generally some of the most costly conditions to treat. For example, heart failure alone remained one of the most expensive conditions to treat in 2016, costing the Canadian healthcare system over $575 million. There's mounting interest in the broader population-wide health approaches to help determine and mitigate these increases in cardiovascular diseases, especially because they're so closely tied to health behaviors such as physical activity. One of these approaches is to look at our neighborhood-built environments and whether they're designed in ways that allow or encourage physical activity, and the evidence coming from our research team seems promising. For example, one of the most important antecedent risk factors of cardiovascular disease is obesity. We found that men who moved from neighborhoods that are conducive for active lifestyles to neighborhoods that were less conducive exhibited a steeper rise in BMI over time, while men over the same period who lived in less conducive neighborhoods and moved to more favorable neighborhoods exhibited a tempered, more gradual increase in body mass index over time. Our recently accepted study demonstrated a protective association between these neighborhoods that encourage active living and premature cardiometabolic mortality in older women. So far, only a couple of ecological studies have investigated whether built environments, though, might be associated with reductions in healthcare use. And so we ask whether there's a relationship between active living environments and cardiovascular-related hospitalization. What we've done is our research group has derived these measures of the active living environment. These are neighborhoods that support, encourage, or promote physical activity. And it's a national data set derived using geographic information systems, and importantly, is derived using free and open data sources such as census information, as well as OpenStreetMap data. And the measure itself it's a composite measure consisting of three elements: intersection density, dwelling density, and destination density. For this analysis, we used Canadian linked data. So what we did was we used respondents of the Canadian Community Health Survey. We linked these individuals via their postal code to their Canadian active living environment measure that corresponded to their neighborhood. For these individuals, we have a host of sociodemographic and health behavioral information, but we've also linked these individuals to their hospital records in the Discharge Abstract Database. This is a national census of acute hospitalizations, as well as the Canadian Mortality Database, so their date of death. And so the mechanistic framework for these studies are that active living environments encourage walking and possibly overall physical activity, although the evidence is stronger for walking in the literature. And this in turn mitigates cardiovascular diseases and cardiovascular disease-related hospitalization. And what we'd like to determine is whether we can see an overall association between favorable active living environments and lower cardiovascular disease-related hospitalization. So the way we did this was we took a baseline to be either survey response or 2004, and we followed 277,000 individuals that were over the age of 45 to the end of the hospitalization data that we had, or to death. And we modeled the relationship between active living environments and odds of hospitalization for all causes or for cardiovascular related diseases using logistic models. And we also use a mediation analysis to see whether this relationship was mediated through walking or through overall leisure time physical activity. And we adjusted for a number of individual level factors. We found that there were incremental reductions in the odds of hospitalization for both all causes and for heart attacks, comparing the most favorable active living environments to the least favorable active living environments. And although inconclusive, there was some evidence of incremental reductions for the odds of hospitalization for heart failure as well. However, we didn't find any evidence of an association with hospitalizations for stroke. Our mediation analysis indicated that a modest 4.27% of the protective relationship between favorable active living environments and odds of hospitalization for heart attack was mediated by walking, while an albeit inconclusive 14% of the relationship between favorable active living environments and odds of hospitalization for heart failure was mediated by walking. However, there was no evidence of mediation through overall leisure time physical activity. And so our overall findings are that for those living in more favorable active living environments, these people demonstrate on average a lower odds of all-cause hospitalization, around a 17% reduction, of heart attack, around 22%. And although the incremental pattern was visible, reductions for the odds of hospitalization for heart failure were inconclusive. And of course, there were no differences in the odds of hospitalization for stroke. We also found that there was modest evidence of a mediating effect through walking, but not for overall leisure time physical activity. Overall, the study implies that neighborhoods could affect the cardiovascular health of Canadians later on, and that this could be happening in part through increased walking rates. This work signals that if we start to think about designing and improving our neighborhoods in ways that encourage active living, that we may see long-term population health benefits and prevent cardiovascular disease-associated hospitalization burden and perhaps hospitalization costs. And with that, I'd like to thank the funders of this study, as well as the co-authors of this study, the Geosocial Determinants of Health Research Group, as well as Statistics Canada for access to the data.